Good morning, everybody. As always, thank you for all of you who are joining right now. We always give it just a moment for everybody to come in, so I'm just killing time so everybody has time to jump into the webinar this morning. As usual, just a couple notes. First off, thanks for everybody who joined both in person and, of course, online for our State of the Department this week. We have it going on YouTube, and we will send an email out to everybody for those of you who missed it. Thanks a lot for everybody who helped contribute to that. And as always, like any of our communication efforts, if there's any sort of feedback, I extremely appreciate it. So please do feel free to reach out to me about anything in any way as far as how we can be updating it. Things like the annual report, State of the Department, our weekly newsletter, as well as our grand round. So please feel free to reach out about all those things. Before I turn it over to Dr. Salas, I just want to mention next week, the day before Thanksgiving, we have no medical grand rounds, both in person or on Zoom. So please don't try to join. I usually get one or two people emailing me. And so please, we'll send reminders out for no medical grand round. So nothing next week. I hope everybody has a wonderful holiday week. And then we'll return the week after with Dr. Christopher Gardner with the title Precision Nutrition Ready for Prime Time. As many of you know, Dr. Gardner is one of our main researchers in the field of nutrition, and he's going to join us to talk more about what you should be eating then. So with that being said, I want to turn it over to Dr. Salas, and also as often when we have really wonderful presenters like we do today to honor important things like Native American History Month. Thank you to Dr. Salas, also Dr. Harmon and Don and Casteras, who have helped a lot this year. We've had this amazing series of speakers this year. Thank you for helping set up and bringing top presenters like we do have today, Dr. Wescott. So thanks for that. I'm going to turn over to you, Dr. Salas, and thank you for helping MC today.
Oh, thank you so much, Dr. Estalga. It's a real pleasure to be part of the Medical Grand Rounds experience. Would you mind, Roussel, sharing the slides? Excellent. We just have a couple of quick announcements, and then we'll get to Dr. Wescott, who is our honored guest today. So first off is we have coming up in the week after Thanksgiving, an inclusion rounds again, to honor Native American Heritage Month. And this is going to be entitled The Speed of Trust, Trouble Engagement, and the All of Us Research Program. So for folks who aren't familiar, this is a research program that is part of the NIH's programming. And we have two of the folks who kind of lead that effort joining us. So that should be a great inclusion rounds. You can scan that QR code that you see on your screen to register. I'll also put the link in the chat in just a minute. And then a note, as Dr. Estalga mentioned, no medical grand rounds next week. And then the week after, we have this precision nutrition talk from Dr. Gardner. And then the next thing that we're going to have before I introduce Dr. Wescott is actually a land acknowledgement. And there are many different ways to do land acknowledgements. You can go to the next slide, Roussel. Many ways to do land acknowledgements. This is actually what we thought we would share with you today is the land acknowledgement that the university has put together. And this is just a very short video done by or recorded by a couple of students at Stanford. So it's very short, bear with us. Go ahead, Roussel.
Stanford sits on the ancestral lands of the Muwekma Ohlone tribe.
This land was and continues to be of great importance to the Ohlone people.
Consistent with our values of community and inclusion,
we have a responsibility to acknowledge, honor, and make visible
the university's relationship to Native peoples.
Oh, I see a note that the video was, yeah, I got an error saying that the, or not an error, but I was able to see the video, but if you couldn't, it said my screen sharing was paused, so I'm not sure why. So what I will do is I will put the link into the chat for the land acknowledgement. It's 48 seconds. Please do watch it. And the basic gist is that we sit on the land that belonged to the Muwekma Ohlone tribe, and we have to honor that. And we should honor that every time that we have gatherings like this and acknowledge that this isn't land that I or any of us own. So that was the gist of it. I'm sorry I didn't say it as eloquently as it is in the video. Oh, Dr. Golden heard the video. Great. Hopefully some of y'all heard the video. If not, I will again put the link in the chat. Please do check it out. There's actually a lot of great information on the website that I'm going to put the link to. So with that, okay, Roussel, I think we're ready for our Dr. Wescott intro slide. Excellent. Okay. So I am so delighted that Dr. Wescott could join us today. I first met Dr. Wescott in pre-pandemic times, which feels like a lifetime ago, at an AMA meeting. Dr. Siobhan Wescott grew up in Alaska, where she was inspired to increase the representation of American Indians in medicine. She is currently an endowed professor of American Indian Health at the University of Nebraska College of Public Health. Prior to this, she was the co-director of the Indians into Medicine program at the University of North Dakota, which has trained more than 250 Native American physicians. She works with the AMA and the Association of American Indian Physicians, or she worked with the AMA, or works with, I think still, the AMA and the Association of American Indian Physicians to organize an annual summit focused on diversity in medicine. She has also been extremely active in the AMA and is currently the chair of the Minority Affairs section. She has also become the inaugural director of American Indian Health at University of Nebraska, where she holds the Dr. Susan and Suzette Flesche Professorship of American Indian Health. Dr. Wescott is a real leader in medicine and has been featured for her work in Aspen Health, Stat News, and The Lancet. She's also been selected as one of the 2022 status list by Stat News, which is a list of influential people in healthcare. So we are so honored that you're here with us today, Dr. Wescott, and joining us from Hawaii, where it's a little bit darker than it is here. Hopefully the sun will come up while you're speaking to us, and thank you so much.
Thank you, Dr. Sallies. It's a pleasure to be here. And I just want you to know while I'm sharing my screen that there were about 5 different terms for the Native population that were used in that introduction. And I will let you know there is no good term. If you're going to say, what's the right term? Alaska Native is actually selected by a tribe in Alaska, so that's slightly better, but all of the other ones are imposed. And keep a lookout in the next year, and I'll certainly forward this on. We're publishing a study on what terms have been used over the last 50 years in the medical literature, and it's quite disturbing. So it's just a little bit of a spoiler alert. But this is when I was in med school, they asked us to study the summer before and show pictures of us studying the summer before neuroanatomy workbook. So this is me at a powwow and getting some help with my studies. But I did actually spend 2nd through 8th grade school year at Stanford. My mom was getting a PhD. So there I am at 104F in Escondido Village. I'm very familiar with Stanford, and I would spend summers in Alaska. But about that time too, also, that was my first trip to Hawaii, where I'm joining you now. We just finished up the AMA meeting yesterday. So 1974, I just want you to pin that moment. Seems like forever ago. I mean, everything pre-pandemic seems forever ago, but since then, yesterday, the world population has reached 8 billion. So the CDC got it slightly wrong here in their 2011 prediction. They thought it wouldn't be until closer to 2030, but we reached it yesterday. But at the time that photo was taken of me in Hawaii, we were at 4 billion. So we have doubled in population since then. However, for natives, it had only been 50 years in the early 70s since natives were allowed to be U.S. citizens. So this is, again, their land, and I acknowledge that I am on the land of the Hawaiian Kingdom, which really was not properly taken over, or say it was very complicated and really not done right, that the U.S. owns Hawaii. It's only at that time in the early 70s, it had only been less than a decade when natives could vote in all 50 states. So even though it was in the 20s that they were allowed to be citizens and theoretically allowed to vote, it had to go by state by state. So I think Arizona was the holdout. But at this time, it was still, they were not allowed to practice their religions. And there are 570 some tribes in the US. So each one may have a slightly different take on their religion, and all of them were illegal up until 78, as well as children could still be taken away from their families and sent to boarding schools. And you may have heard some of that. I'm not going to talk about that much today, other than to say that my own mother was sent to boarding school, and it was a traumatizing experience. But I theoretically could have still been taken from my family because the law hadn't changed yet. So this is not ancient history. Although the world population has doubled, there was still some long shadows of policies that were just barely starting to change a couple generations ago. So I'm gonna jump forward to today. You may not have seen this, and I've asked Dr. Salis to drop the link in the chat. There were provisional life expectancy estimates for 2021 came out in August. This is unprecedented. Well, like probably the 1917 influenza epidemic would have been the last time that we saw a dip in life expectancy for everyone. So it's quite dramatic, but in those numbers, if you look at life expectancy for a native baby born today, and this is one of my MPH students and her son, Animiki, which in their language means thundercloud. So I love this photo that I took of them, actually, because it's with a thundercloud. So Animiki, compared to a white baby born today, will live 10 years less on average, and 16 years less than an Asian baby. So, and I'm going to keep this talk very general because I always have lots of questions. So if there's disease specific questions about the native population, I'll answer those, but pretty much with the exception of, say, cystic fibrosis, there's going to be an inequity. You just don't get to these poor life expectancy outcomes without a lot of health inequities. So I wanted to focus on something positive before we get into some of the more controversies, and to really emphasize the ingenuity in Native cultures that should be tapped into. So if you've ever been on a trampoline, this was the inspiration, and it was actually extremely practical. So this is what's called the blanket toss, and it's in parts of Alaska on the coast where they need to look for whales that would feed an entire village for a winter. But there aren't many trees, and the whales move a lot, so you couldn't really have structures where you could see into the sea where the whales would be, so you could hunt them. And so they came up with this ingenious solution to create a blanket out of hides, and then one person gets on the blanket, and the entire crew or village pulling coordinates to put them up in the air so that they can see where the whales are. I love this because, first of all, you have to work together. And for those of you who have thought about working with Native communities or have tried already and found some frostiness, part of that hesitation is because for a lot of tribes, survival meant working with your own, and outsiders have been maybe not doing the best things, certainly. And I'm going to go through a couple of those. However, when the tribes themselves work together with their own, amazing things happen. So some of that is an innate unwillingness to trust outsiders when your survival for thousands of years counted on working with your tribe. So I'm slightly out of order. I do work with the American Medical Association. Actually, we just finished up yesterday with our interim meeting here. It was in Honolulu, and you can see that the sun is starting to come up just as we're talking about the brighter things of advocacy. So a couple of things I wanted to talk about. Oh, I see. Sorry, this is the wrong. I don't know if Twitter will survive this month, which is Native American Heritage Month, but this was quite a controversial tweet from the Journal of the American Medical Association media team, and it was advertising a CME podcast, so you could get continuing medical education credit. So you're supposed to learn something from this, that no physician is racist, so how can there be structural racism in healthcare? And an explanation for the idea is a podcast, and it was really a demonstration of structural racism rather than how to dismantle it. One of the notable quotes was the sentiment that there couldn't be structural racism because it was made illegal in the 60s. So this kind of thing still happens. This was last year. And it did eventually lead to the changing of the guard at the editor-in-chief position at JAMA. And now, actually, I believe Dr. Bibbins Gonzalez is a Stanford affiliate, or had been. But here's an example of why outsiders are not trusted. So a med student went to Alaska and was able to go to a very remote village with an attending who'd been taking care of patients there for 10 years. And he wrote a piece about his experience, and it was published in JAMA called 5 Miles from Tomorrow. And it was about a patient that 97-year-old who decided he wanted to commit suicide in the tradition of the tribe, where it's accepted by the community, and that they simply walk out onto the Bering Sea ice and are never heard from again. So that was published in 2001. It's finally actually I just wanted to give you some perspective. So here's, and I don't have the international dateline here, but so the community is 5 miles from the international dateline. So 5 miles from tomorrow. It's quite a clever title, but it also makes this village identifiable. The attending physician who vouched for the med student replied that this was a fictitious story, that there was also no such tradition. And it's been cited as an unethical example by the British Medical Journal Ethics Committee. It was only retracted this year, and I've actually spent the last 5 years trying to get this pulled. And if you really want to take a deep dive, the author retracted it, not really fully understanding why people were upset, but he realized people were upset. But this type of thing where elders truly, there's no pan-Indianism, there aren't universal truths, but the closest to that is that elders are revered. And so saying that we'll just let them kill themselves with our permission is really insulting. So things like this from a med student, and having been a med student not really that long ago, I graduated in 2008, you don't feel like you have any power, but clearly this story had resonated. And I heard from some of my public health students that they were taught that this was a tradition because of this article. So this is one of the reasons that outsiders are not trusted. So let's brighten things up as we get more of the morning sun. again, I just finished up with the American Medical Association interim meeting. This is from an earlier meeting. A lot of the same folks are involved. We're very much speaking up, but one that you'll appreciate is that we reinforced the notion that abortion is a human right and should be an essential part of healthcare. Sometimes in interviews, and I will give immunity to anyone who might be guilty of this, people are not sure when someone clicks the box American Indian Alaska Native if that means that they actually are, and a way to ask about that is what's their blood quantum. That gets into some very complicated politics and is not appropriate in the setting of interviews for either medical school or residency. I think the better question is, what does being Native mean to you? Help me understand. Keep it simple. So that was just what we passed this week. Earlier on, and I was a part of the task force that created the Center for Health Equity, and we really struggled because this term gets thrown around a lot, but what does it mean? So health equity definitions were all a paragraph long, and they lost you after the first sentence. Dr. Rhodes came up with a beautiful definition that is simply health equity is optimal health for all. So I think that's a great way to think about it. And there certainly are a number of ways that things are unequal for American Indians, Alaska Natives. And there is the Indian Health Service, which is, if you think about it, and you may never have, but now you can, American Indians, Alaska Natives are the only population in the US born with a right to health care. Even with that, their life expectancy, again, 10 years less than whites and 16 years less than Asians. So we've got a lot of work to do. With that, again, I'm leaving lots of time for questions because there's always a ton of them. I will simply say thank you. This is my email. I will also put it in the chat when I stop sharing, and I'm happy to take questions, and we can have hopefully a good exchange.
Thank you so much, Dr. Wescott, for introducing this topic and covering actually quite a few different areas of content. I'll just start with some questions that are in the chat. So one simple one, or I hope it's simple or straightforward, is related to what you were just talking about when people ask about Native heritage. And this person says, what is blood quantum? So maybe if you could explain that for us.
I could. So where to start? Blood quantum is the percent that you are Native. And this was instituted probably in the 1800s. I don't know the exact origin. So long before genetic testing, although all of that genetic testing is very suspect. But there are certain rights that you had access to at different points in time. So for me, I'm Alaska Native. And in that photo of me in Hawaii, it had just been a few years since the Alaskan Native Claims Settlement Act. But in that act, it defined who could be federally recognized amongst Alaska Natives. And you had to be a quarter. So your blood quantum had to be a quarter Alaska Native. So that's where the concept of blood quantum comes in. It's almost entirely federally dictated. We're moving away from that for a lot of tribes, but there are some tribes who still use it for who can be enrolled. And enrollment has privileges. One of the most important to me is that who can own eagle feathers. And own is really not the word. Who can have eagle feathers? So if you're not an enrolled member of a federally recognized tribe, you cannot have them. There are also rights with access to healthcare. And I will say, this is another question before it's asked. The Indian Health Service is not insurance. And as an enrolled member of a federally recognized tribe, I cannot go anywhere and say I should have healthcare. I have to go to where there are Indian Health Service clinics or services to access them. So if you get a referral from a California tribe, for instance, that's contract services, but it's Indian Health Services, not insurance.
Yeah, that's a helpful distinction. And thank you for sharing that about the origins of this blood quantum measure. There's another question in the chat about the life expectancy data that you had shared, and you kind of alluded to some of the reasons for that discrepancy. But I was wondering if you could share a little bit in a little bit more detail, kind of all the, well, not all, but some of the different factors that contribute to that discrepancy, especially given what you just shared about, Native American people being the only ones born with a right to healthcare. So and maybe you could unpack that for us a little bit. And then the question that came through the chat related to that was whether there's any less of a gap in those outcomes, in those life expectancies, if we control for other variables such as BMI.
Mm-hmm. Yes, so I got the census is from the National Center for Health Statistics, and it's provisional is in the title, that there's a lot more to unpack, but they just wanted to get out the disturbing information that everyone's life expectancy has gone down, but it has not gone down equally if you look into the data. I don't think they've done that close of an examination, and I'm certain that there will be differences once someone does. I will say the Native population in the US, around 9 million now as of last census, much younger than the rest of the general population, and BMI does tend to be higher. I think we'll come up with some other ways that other social determinants of health that may also influence the life expectancy, but I think they're still crunching some numbers.
Yeah, I appreciate that answer and sticking to, what's in that report. I'm just curious if there's anything else you could share just based on what you know already, as to what some of the factors might be, or just kind of like muse about it, if you will.
Okay, well, BMI is going to be one of them. Diabetes is going to be one of them. And I will say the NIH had a long-standing study with the Pima Indians, which at one point had over half of the adults, those are individuals age 18 or older, with a diabetes of type 2, with a diagnosis of type 2 diabetes. So in the 90s, when genetic testing was coming to life, so to speak, NIH said, oh, if there's a gene for diabetes, it's probably going to be with the Pima. So this is one of the areas where it actually significantly influenced the terms that we found in our study, in our survey of terms used in PubMed over the last 50 years. Pima Indian influenced the number of tribe plus Indian, and also our terms outside of normal, like Native American or American Indian, just because of this study. Really, the tribe got very frustrated with them because they weren't trying to do interventions, they were trying to find the gene, and quickly found that there was not a gene or gene suspects. And largely it's because of the Hoover Dam having relocated them, and they were no longer able to continue their traditional lifestyle and relied on commodity foods, which were very unhealthy. So, it's social determinants of health, social determinants of health, social determinants of health. So when you look at BMI, you also need to think, well, why might that be? And it, even beyond living in a food desert, which a lot of reservations are in, you also, when you look at the commodity food programs, they're getting slightly better, but commodity cheese is like a giant golden block of chemicals and lots of fat. So, and for a long time, lard was actually, yeah, lard was given. I mean, can you get more unhealthy? I can't, I'm challenged to think if you can. So, if I'm not answering directly, it's because if you scratch the surface of any of these things that clinically we immediately go to, well, maybe this could explain it. And you always have to look at the social determinants of health that are raising those risks. The other thing that I will say is that substance abuse seemed to be quite influential in that lessening of life expectancy. I did take a look at this data, and they always with data on natives, you have to check how they figured out who is native. Sometimes it's not that bad. Sometimes it's just self-identification, and while that may be slightly problematic, it's reasonable. Sometimes it's just someone in the healthcare system decides who they are, and death data is the worst because families are grieving. There's not a set person or role that fills out the death certificate. So someone who doesn't want to bother a grieving family may just guess, well, the last name is Gonzalez, so I'll say they're Latino, or Hispanic. These are death data is notoriously inaccurate.
Yeah, that's very helpful. And I really just wanted to underline this point that you made, that even when we think that we're identifying a health disparity, like in BMI, was the question, what's the cause of that? What is the etiology of having differences in that, or rates of diabetes? And I think you really illustrated that very well. Thank you. I'm going to go. I thank you all for the questions in the chat. Please keep those coming. I'm going to go back to those, or in the Q&A, I mean. I'll go back to those in a second. But for now, I'm going to turn to Dr. Dunn, who wanted to ask a question.
Good morning. Thank you, Dr. Wescott, for that wonderful talk. We both did land acknowledgements today, and obviously we want to honor and show gratitude to those who inhabited the land originally. We've talked a little bit about this in our department, about how we continue this tradition moving forward without feeling performative or inauthentic. And I wondered if you could share with our community some ideas or suggestions for best practices and how you feel about land acknowledgements in these, obviously non-Indigenous people.
Yes, so I'm just hesitant to talk about them because I don't know for precisely the reasons you said, is that they came kind of splash a couple of years ago, and I feel like they're losing their authenticness. I do love the video that you had, and maybe you update that every year with new students. I would probably add some elders. I think that's a way to keep it fresh, because things that we see too often, and I think of the transition. So I was in med school at the time. We were going from paper charts to Epic or other EHRs at the time, but I still have nightmares about Epic. But when you see an Epic visit summary and you've seen 1,000 of these, you stop looking at the details. And that's what happens when you use the same land acknowledgement over and over again. So I think mixing it up, slightly different words, different people sharing it, I think that could help keep it fresh.
Thank you.
Yeah, thank you so much for sharing that perspective. There are still some more questions in the chat. One of them is about the AMA specifically. So the question is, does the AMA still have a program for physicians to fill in at Indian Health Service facilities, hospitals, or rancherias?
I'm not aware of one. The Public Health Service does that. There are, well, actually during the pandemic, very early on, Navajo Nation was one of the locations that Doctors Without Borders came to, and that was the first time they'd ever been on American soil. So I'm not aware of that particular program. I will say that the Indian Health Service now, try and imagine everybody think of their department. If you had a 20 to 25% vacancy in physician positions, would you be able to do your jobs? So that is the typical physician vacancy rate at the Indian Health Service. So any of those programs are definitely needed.
Wow, that's a huge gap. Thank you for highlighting that. Another question from the chat is kind of practical for us. What are some strategies for educating and approaching medical education related to, to raise awareness of the challenges and the data that you shared and how we can, change our systems really to be more equitable? It's a big question, but just a few thoughts would be great to hear.
Well, and it's hard because medical education is trying to do 500,000 things, and I'm exaggerating for effect, but it does feel like that. So Dr. Redvers, who is a naturopathic doc and an MPH from Canada, is trying to get us to transition from cultural competence to cultural safety, because are you going to be able to know everything about every patient culture that you work with? Probably not. And even as an Alaska Native, when I'm working with Nebraska tribes, that's a different culture. There are things that they do that I'm not aware of, and vice versa. So, there's this idea of cultural competence is probably too ambitious, especially for the limited amount of time. And my favorite definition of cultural competence was from one of my classmates, which was simply the ability to laugh at oneself when you get it wrong. But I think with the same, I tell you, I get a lot of questions like, what is the meaning of a powwow? Or just somebody's heard something and they want me to confirm or, share more about some scintillating thing. And that's really where the problem with 5 miles of tomorrow. That's the greatest example of that. It's better to ask, I've heard about powwows. That's really interesting to me. Can you share some more of that? And actually, the first powwows that I remember were at Stanford. So this is a full circle moment. However, I think the best way is to assume to assume that you need to do trauma-informed care with patients of color. And if they don't seem to be traumatized or trust you immediately, then, proceed as usual. But generally, you should think that you need to earn the trust of your patients of color, because many, many bad things have been done in the name of medicine or research to people of color, and especially American Indians, Alaska Natives. I've only given a couple of examples, but there are many, many worse. And I think forced sterilization without their knowledge is one of them that has really had long-term impacts. So, your patients who are exotic to you may look at you as a threat, not as, oh, I'm at Stanford, I'm going to get great care. So that's just a paradigm shift that you may need to make.
Yeah, that's an important framing for us to all keep in mind. There are a lot of questions. I don't think we're going to get through them all, but we'll just keep making progress as we go. So one question, there's so many, they're all good. One question is related to some of the work that you did when you were in North Dakota, which is, what's your suggestion for improving or increasing the pipeline of health providers of Alaska Native American, Indian, or Native American heritage?
Okay, so actually just this week, I learned that AAMC has this data, but I've seen statistics, and it's just a guess that 50% of med students in the US have a first-degree relative who's a physician. So that is a huge advantage. Probably it's a financially stable family, and someone to help you navigate through all the unwritten rules. So I think of, and we prefer pathways because pipelines leak usually on Indian reservations. So the pathway programs is not just let's help you increase your MCAT score to a competitive level. It's got to replace someone walking you through every step. So it's a much bigger scale, and that is expensive and time consuming, but it's what's needed if you're going to get really parity, which we're far, far below.
Yeah, that's an important point. All the other resources that some people have access to, or differences in what resources people have access to, definitely can affect outcomes. There's a question about the rising levels of suicide in young people. And the question is, how have different tribal groups, to your knowledge, been dealing with this internally? Obviously, this is a broader societal challenge, but I think the person's just asking within tribes that you're aware of, or how are they handling that or responding to that?
Yeah, it's definitely a real struggle, and it's just heartbreaking, especially when it's a younger person with their whole lives ahead of them and they can't see a future. I think some of my favorite programs involve elders pairing up with vulnerable youth, and I think that's a really lovely way, but a lot of this isn't being shared. And tribes have that right to keep their data and their programming to themselves, but it's just not an area that I know specifically much about the programs that are available.
Yeah, that makes sense. There's another really important question about the Supreme Court case.
Yes.
On adoption of Native children. So I wondered, the person's question was, can you comment on it? So it's pretty broad. What are your thoughts on the case? And probably it would be helpful to give some background, because I'm guessing not everyone has followed that super closely.
Yes. So the law of the land currently is the Indian Child Welfare Act, and it protects Native children so that if the child needs to be removed from the home, that they go to a relative, tribal member, or other Native family before being adopted out. And I will say the impetus for this was largely to protect Native children from Mormons. Mormons really had a very ambitious and coercive programs to bring Native children to Mormon families when they had intact families, so to saying, better opportunities. It was really quite despicable. And so the Indian Child Welfare stopped things like that. However, it's been under attack lately, and the current case that's before the Supreme Court and was just heard, I think, a week or two ago. Oral arguments were heard. I believe it's a family in Texas who's saying the Indian Child Welfare Act, the white family, is preventing them from being able to adopt a Native child, and that was against their rights. So I think that's a good way to stay out of touch. But nonetheless, it's a court that will probably side with them. I will say the American Medical Association and the, I'm forgetting the pediatric organization, both jointly gave an amicus brief saying that the Indian Child Welfare Act should be maintained.
Yeah, so the Indian Child Welfare Act, the idea of the act, right, is to prevent adoption of Native children by other groups, right? Yeah, and that's the case that's being heard right now. I don't think we've seen a decision yet. Okay. Yeah. Thank you for that context. There's a question about something that I actually don't know what this stands for, but I'm going to ask the question in case you know what it stands for. It says, can you give some background on tribal health structures now as the PHS provides. I'm unfamiliar with current tribal health structures, individualized or affiliated with local. And I don't personally know what PHS is, but maybe you do.
Okay, so it's the Public Health Service, and that's the umbrella for the Indian Health Service. And actually, in the early 70s, finally, the federal government started recognizing that tribes could handle themselves and should have those rights. So there was the law 93-638, and I'm mentioning this because we use 638 as a verb. So the 93rd Congress, 1971, I believe, 638 bill passed into law, laid the groundwork so that tribes could take over their care from the Indian Health Service and the federal government. And this comes with incredible advantages if they can pull it together to manage their own care. And I don't think in California, there's an Indian Health Service hospital, but Phoenix and Alaska, and I think Oklahoma, as well as Navajo, there are tribes banded together, they 638'd together, and were able to create regional hospitals, and they can do things like pay for traditional medicine and things like substance abuse treatment that might not be the priority for the feds because they have very specific regulations they have and priorities that they have to follow. So if the tribes can take it over, then if they're able to stay afloat and make any extra funds, then they can put it towards their priorities, including having traditional medicine on site. So it gets very complicated very quickly.
Yes, I think the question that this person was trying to get at was the level of healthcare provided, or like how it's organized within, whether it's local tribes or with it, individual access, or I'm not totally sure, but
okay. So let me try and clarify, because I think what they're asking is how do natives in the US access Indian Health Service? And if I'm incorrect, please put it back in the Q&A and let me know what you're getting at. So again, Indian Health Service is not coverage for you as a federally recognized tribal member. It is, we provide services at these certain points, essentially based on treaty rights. So you have to go. And I will say, when the pandemic hit, I was in rural North Dakota, and I didn't know when I would be able to get the vaccine as they started to roll out. And I reached out to a fellow physician who's at the Minneapolis Urban Indian Health Center, and she said, "We're not taking your age yet, but get signed up." The very next week, they got me in. So I did a 10-hour round trip drive to Minneapolis twice to get vaccinated. And I can probably say that the Indian Health Service might have saved my life, because at that time, North Dakota had some of the highest rates in the world of COVID. So, but you have to go where they are.
Yeah, that's very helpful. Thank you. I think we have just a few minutes left, but I was wondering if you could share with folks some of the work that you're doing now in Nebraska, because I had seen an interview that you gave where you talked about kind of the challenges of working with different tribes and trying to get everyone kind of engaged in an effort. Would you mind talking a little bit about that, what your work is now and how, the challenges that you're facing?
Sure. And I will share, if you have any interest in any issue related to American Indian Alaska Native health, you can probably make a difference, even if it's a scoping review or reaching out to a tribe or some entity that helps Native populations. You can make a difference because there's so much work to be done. And even in my experience as a Native person, I'm still an outsider. They give me maybe the benefit of the doubt but I still have to do a tremendous amount of work to build trust. And I start small. I start with grants to the tribes, all of those things from a trauma-informed perspective, because those tribes have seen things happen. And this is why in your introduction, you said that I was director of the first American Indian program at the University of Nebraska Medical Center, is because something would happen here, something would happen there, and then, oh, that one ended, and another one kind of started, but then didn't get off its feet. So there was no coordination. Things were haphazard, and tribes see that as a lack of commitment. So my work is to show our commitment. We mean it. And that will help you working in any country, but do remember that you will have to do extra work to earn their trust.
Yeah, and imagine that's a lot of, conversations with the key stakeholders, and, what are the other strategies that you use to kind of build that trust? Like you mentioned, giving grants. But if anyone here listening, wants to do this type of work, what are some key strategies for building partnerships with tribes?
Okay, if you're not Native, you find a Native physician or someone in public health to make those introductions for you, because any outsider making a cold ask to a tribe or some tribal entity or some group that works with Native populations is going to be a tough sell. Now, maybe the Stanford name will help, maybe it won't, but it's definitely, you need a partner who is Native or has at least worked with them extensively and has been accepted in order to get anywhere.
Yep. Yeah, that makes a lot of sense. Well, I think we're pretty much at time here. There's one comment that I want to share from the chat or from the Q&A, which was that it would be important to assess ACEs, adverse childhood experiences. I think that was in the context of the conversation of how we care better for folks from different backgrounds. So thank you for that comment, Dr. Yen. And yeah, with that, I think we'll stop. Thank you so much for your time, Dr. Wescott, and for all the work that you're doing. We really appreciate it. We need you, obviously. And I very much look forward to hearing more about your work and how we can further support the efforts of you and the AMA's Group on Minority Affairs and everyone else trying to change the face of medicine in this country. So thank you all for being here. That's the end of our grand rounds for today, and everybody have a lovely day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.